All right, good morning, everyone. My name is Megan Cluth, and I'm with the Colorado Respite Coalition. On behalf of the Respite Coalition and JFK Partners, I want to welcome you to the fourth of our 4 webinar series this year, which is Understanding Challenging Behaviors. Today's topic is Understanding Challenging Behaviors in Older Adults. So far we have about 25 people registered, with the majority joining through live webinar. We're recording today's events, and we will archive it on the JFK Partners website and the Colorado Respite Coalition website. And you can also view our other webinars from the series on there as well. Following the webinar today, you'll receive a link requesting an evaluation. You may request a contact hour in the evaluation. It will be emailed to you within the next week. Web participants can ask questions via the chat box. Please be sure to mute your video and microphone throughout the presentation. For those here in the room, we'll hand around a microphone if you have questions. So today we are very lucky to have 2 speakers who are both experts in the older adult area. We are going to get started with Stacy Naslin this morning. Stacy's going to talk a little bit about dementia and dementia-related behaviors, and then we'll hand it over to Amy Miller to talk more about mental health and some other considerations for possible behaviors in older adults. So before we get started, I'll read their bios for you real quick, and then we'll hand it right over to Stacy. So Stacy Naslin has been working with the senior population, specifically people with dementia, for the past 15 years. She is currently the executive director at Spring Ridge Park Assisted Living in Wheat Ridge, a community that is exclusively for memory care. She's an active volunteer with the Alzheimer's Association and enjoys teaching the community about dementia. She's a member of the Jefferson County Aging Well Project, Caregiving and Supportive Services Work Group, and also sits on the Jefferson County Council on Aging. In addition to her community work for Jefferson County, she is also a founding member of the Dementia Friendly Movement, where the goal is to educate and make Denver a dementia-friendly city. And then following Stacy's presentation, we will have Amy Miller. Amy is a licensed clinical social worker in Arvada, Colorado, with a broad range of experience in the field of aging. Amy's work experience includes primary care settings, skilled nursing facilities, and a variety of nonprofits. In her previous work at the Alzheimer's Association, Amy was involved in developing 2 curricula used nationally to educate caregivers on communication strategies and dementia-related behaviors. Additionally, Amy developed a protocol for assessing and intervening suicidal constituents, which was shared nationally within the Alzheimer's Association. Amy was also the primary author of the Roadmap for Advanced Planning, which was created by the Jefferson County Aging Well Project. As the Senior Reach National Consultant, Amy has been involved with the training, implementation, and ongoing support for the 13 Senior Reach sites in Colorado, Michigan, New Jersey, and Montana. Amy also oversees the day-to-day operations of the Senior Reach program at Jefferson Center and has been involved in training the other community mental health centers in Colorado on working effectively with older adults. Amy earned her BA degree in psychology from the University of South Dakota and her Master's of Social Work from the University of Denver. She's also a certified mental health first aid instructor. So thank you both for our speakers, and we will go ahead and get started with Stacy Naslin.
Hi, good morning. Thank you so much. So today I'm going to talk about understanding and responding to dementia-related behaviors. Like Megan said, my name is Stacy, and I am the executive director at Spring Ridge Park Assisted Living. And thank you. And so yeah, today we're going to talk about responding to dementia-related behaviors. I don't like to call them behaviors always because they're usually a reaction, and we'll talk about that a little bit more. But today's objectives, we're going to identify common triggers, which I categorize as the big 5, so we'll explain what that is, and we added some too, so a little more than 5. We're going to assess and identify challenging behaviors / reactions. Again, I don't like to call them behaviors always because it's usually triggered by something and they're having a reaction to something, usually an unmet need. So the third part of our objective today is identifying strategies to address those common behaviors or reactions. So to begin, we're going to talk about just kind of some changes that are going on in the brain of someone with dementia, Alzheimer's. They are saying now that there are over 130 different kinds of dementias. Alzheimer's is the most common form of dementia. About 70% of people with dementia have Alzheimer's disease. So that's why we hear about it most commonly. The top picture there is the comparison between a healthy brain and someone with advanced Alzheimer's. Alzheimer's is a disease, is a progressive brain disease So you can see what happens in an advanced Alzheimer's brain. It's smaller, it's shrunken, and there's big holes in that brain. So that's where we get our deficits. We think of Alzheimer's or dementia sometimes as just a memory disease. It's much more global than just memories. It affects every element of thought: perception, organization, language, abstract thought, reasoning, judgment, attention span, and finally memories. But we think of it as a memory disease because of where it starts. It starts in the hippocampus, and that is the part of the brain that controls our short-term memory and our new learning. So that's why we usually think of it as a memory disease, because short-term memory is the first to go. I really find the bottom picture quite interesting. You can see it's a PET scan of all the way on the left is a normal brain, lots of brain activity going on there. The warm colors, the red, the orange, the yellow, are the active parts of the brain. In the middle, we have the late stage Alzheimer's brain. You can see a lot less of that warm color activity going on there, dramatic loss of function. And then the slide next to it on the very far right is actually an infant's brain. So it's quite interesting that really the same parts of an infant's brain are the same parts that are still active in someone with late stage dementia. In the middle there, you can see the two kind of kidney bean shaped areas in the middle of that brain. That's the amygdala. And to keep in mind, the amygdala is what controls our fight or flight response. So someone in very late stage dementia, that fight or flight response is still very active. So that's why we talk about behaviors and reactions, because a lot of time that's what's fueling that reaction, is that fight or flight response. Okay, so just a little bit of background there. All right, so common triggers, what I like to call the big five, plus some. So if you really have any of these triggers working against you, this is where you have those reactions or those behaviors. Some of them are pretty obvious. Fear, obviously, you know, and later in the presentation we learned that confusion is the biggest problem with dementia. It is the biggest combative that you have with dementia. So confusion is causing fear. If you're confused on where you are, who these people are around you, how did you get to this place, you're going to be scared and you're going to have some fear. Frustration, communication changes a lot in dementia. So they're frustrated. They can't communicate like they used to. They can't tell you what's wrong. They can't tell you that they're hungry, that they're thirsty, that they're cold, that their tooth hurts. So they're frustrated. So that's going to cause a reaction. Fatigue, obviously. One of the main behaviors that we're going to talk about later on is sundowning, which happens in the later afternoon, early evening usually. And I truly believe that sundowning happens because someone is tired. They're just tired. Their brain has been working all day long to try to keep up with what's going on around them, and they're fatigued. Physical discomfort. This can be either physical or emotional discomfort. So those are, you know, things like it's too loud in here. It's too quiet. I don't feel good. I'm too cold. My stomach hurts. I'm hungry. I'm thirsty. Environment, that also goes along with, you know, it's too bright in here. It's too loud. I'm overstimulated, understimulated. That's the next trigger there is overstimulation or understimulation. And then the last one is staff and family approach. How we communicate and how we are dealing with our folks with dementia can absolutely cause some behaviors to happen. So that's why communication, and we're going to talk about that in our approach and how we deal with them. They cannot make the changes. We have to adjust and make the changes. Okay. So some strategies for success. The first one is obviously meeting those medical needs. Did they have their medication? Are they constipated? Are they getting the right amount of sleep? Are they on the right kind of meds? Are they having a medication adverse reaction to a medication? So meeting medical needs, you may have to consult a physician when you're doing this. You know, we're not doctors, so we really look to those folks to make sure that they are on the right kind of medications, or take them off medications. That's always a good thing to start with. We want to provide them meaningful activity and giving them purpose. I think this is a huge thing. If we can learn to do this and giving them purpose every day, it really keeps a lot of these behaviors or reactions at bay. They are still adults with meaningful purpose and with a good quality of life, and they can still do things. And I think a lot of times with dementia, we try to focus on the things that they can't do or the things that they've lost. But to be successful in caring with people with dementia, if we flip that around and we really focus on the things they still can do, it gives them a better quality of life, and in turn, as care partners, gives us a better quality of life too. We're going to talk about reassuring and redirecting, breaking down tasks. Again, goes into that confusion and that frustration. If you give them too many things to do at once or too many steps to a task, they're just going to get overwhelmed and they're going to melt down and shut down. Build and rest periods goes back to the fatigue. Making sure that they get enough rest, making sure that they're busy enough during the day and active during the day so they sleep well at night. Very easy for our folks with dementia to get their days and nights mixed up. So we need to make sure that they're getting adequate rest during the day, but not too much so that they don't sleep at night. It's a tricky balance there. No personal preferences, and this is family caregivers have a leg up on this one because you know your loved one, you know where they grew up and what their likes and dislikes are and their personal lifestyles were, and you can use that in caring for them. Be person-centered and not task-centered. Again, giving them purpose. Especially when we're in, say, a care community setting. We've got 100 things to do every day, but as soon as we try to rush our folks, when we're trying to get 10 people up for breakfast and make sure everybody's in the dining room at 8 a.m., that doesn't leave a lot of time for person-centered care. That's task-centered. So we really just need to slow down and take our time and really go where they are and meet them where they are. Again, learning and using good communication skills. Communication changes a lot in dementia, and learning to adjust the way we communicate can make us so much more successful. Modifying that environment, again, turning more lights on in the afternoon so that when the sun starts going down, they don't shift into that sundowning. Making sure that the TV is not on all day. Making sure that it's warm enough because they have trouble regulating body temperature. Things like that. That's modifying the environment. And then sharing information with others. When you find something that's successful, share it. Say, hey, I did this today and Mary really loved this. And just remember, what works today may not work tomorrow, but it's always good to keep trying new things. So when we approach folks with dementia, approach is a make or break kind of thing. So when we approach them, we always want to approach them from the front. Someone in middle stage dementia, if you put your hands around your eyes like goggles, this is what someone in middle stage dementia can see. It's kind of the brain's way of compensating. The world around us is too much to take in, so my brain's going to shrink my world to this. That way, so when you're approaching them, of course, if you come up from the side or behind them, you're going to scare them to death. So always come from the front. They also know that you are there for them and you're talking to them. One thing at a time. It's just too overwhelming to try to tell them, okay, now we're going to go to the dining room and I want you to set the table for 5 people and can you put all the cups, and then when you're done with that, we're going to pour the coffee. Like, that's just way too much for them. So one thing at a time. Minimizing distractions. I taught a class one time to a gentleman who would play cards with his mom, and he was really disappointed one class that, she just can't play cards anymore. It's too much for her. And that was like their special time together. Well, we started talking about distractions, and he realized the next time he went to visit his mom that when they played cards, she was facing the window and the blinds were open and there was just people walking by and too much going on. He closed the blinds. She could play cards just fine. So, it's sometimes just as simple as minimizing those distractions. We'll talk about this too a little bit more, but using simple language, very concrete. We call it the long, slow kiss. Keep it slow, soft, and simple. So very simple, concrete language. Again, slowing down. Takes their brains 30 seconds longer to process what we're saying than our brains do. So if you talk slow enough to drive yourself crazy, you're probably right on. Okay, and give them time to respond too. If they don't respond to you right away, give them 30 seconds, give them a minute. If they don't respond after that, then ask the question again, or ask for the response again. Avoid correcting. I mean, these are adults. They don't want to be told that they're wrong. Instead of correcting, redirect, or, you know, turn a positive into a negative. But you know, like all of us, we don't want to be told, no, don't do that. And they are the same way. Be mindful of body language. So only 7% of communication are actually the words that we're using. And especially our folks with dementia start to rely, because language becomes hard for them, using language and understanding language. So they start to rely on everything else, including body language, facial expressions, tone of voice. So be very mindful of that. A smile really goes a long way with our folks with dementia. And we want to give choices, but not too many. A lot of times giving the answer in your question is a good way to give them choices. Do you want to wear the green sweater or the red sweater today? To ask someone what they want to eat is very overwhelming. So do you want a ham sandwich for lunch, or would you like soup? You know, give the answer in your question. So some communication, I have 2 of these anagrams, a couple of the communication techniques. Talk tactics. So think of talk, T-A-L-K. Take it slow, ask simple questions. L is we want to limit reality checks. There's more that we'll talk about here in a minute, but you know, we really want to go to their reality. Join their reality. They can no longer join our reality sometimes. So if we limit those reality checks and just go where they are, we are much more successful. And keep eye contact, because they want to know that you're talking to them. We can also smile, so we can slow down, minimize distractions, instill calm, you know, and we'll talk about this towards the end of the presentation, but we make the weather. Folks with dementia really feed off of our energy. So if we're having a really positive, happy outlook on things, they're also going to be more positive and more happy. And if we're frustrated and upset, they're going to feel that too. And then in turn, they're going to act the same way. We want to look and listen. There's a mantra that we use: don't just do something, stand there. And that's very true. You know, we always want to jump in and help. That's our first instinct. But sometimes we just need to take a step back and just kind of look and listen and reassess what's going on. And then we want to engage. You know, we want to keep talking to them. We want to keep engaging with them, and we want to make their quality of life as best we can. So here's a quote from Tipo Snow. She is an occupational therapist and a dementia care consultant, sort of the guru of dementia care right now. And she says, behavior talks to you. Instead of getting mad or frustrated because the person with dementia acts inconsistently or nonsensical, try seeing behavior as a message. A behavior is like the tip of the iceberg, something to be curious about, investigate, and to explore rather than to judge. And that's absolutely it. Behaviors are a form of communication. So how do we address behaviors? Well, each and every time. And we'll talk about how to do these 4 things, but we want to detect and connect. And part of our job as caregivers is really becoming detectives. And then we have to figure out what's going on so we can connect with that person. We obviously want to address those physical issues first. Then we want to address the emotional issues. And then what we do is kind of reassess and say, okay, what worked, what didn't work, and what can we do next time, okay? So when we're detecting, it's the who, what, when, where, whys, right? Who was involved? What was going on when this behavior occurred? Where did it happen? Because that makes a big difference. Were they at home? Were they out in public? When did this occur? Did this happen in the later afternoon? Could this possibly be sundowning? Is it happening in the middle of the night? And why do you think this happened? Okay, so we have to really ask ourselves the who, what, when, where, why questions. So to connect, again, we approach that person calmly, respectfully. Again, these are adults that we're dealing with. We want to focus on the feelings, not the facts. A lot of times folks with dementia, and we'll talk about some of the big behavior issues that they might have, but hallucinations, delusions, suspicion, paranoia, those are very common things that happen with dementia. And so we need to focus on those feelings behind those statements, not the facts. You know, the statement is, my daughter stole all my money. Well, we can't focus on the fact that the daughter stole all the money. We have to focus on the feeling of why she thinks something has been taken from her. Okay. We have to validate their concerns. A lot of times folks with dementia just want somebody to say, I hear you. Oh my gosh, I'm so sorry that has happened to you. That must be really awful. And instead of just saying, oh, that's not real. That didn't really happen. Your daughter didn't really steal your money. To her, that's a very real feeling. So we really have to validate that concern. We want to reassure the person. Gosh, I'm really sorry that's happened. Let me call the police. I don't know how many times I've called my own cell phone saying, this is Stacy and I'm reporting a theft. And, but to them, I'm doing something about it. So I'm reassuring that person that I've heard them, I'm validating their concerns, and I'm going to follow through and do something. And a lot of times that just appeases them. Then what I do is redirect their energy. Let's go have a snack. Let's go for a walk outside. We'll wait for those police to call us back. And hopefully, the hope is 10 minutes later, they've forgotten all about what they were worried about. But because I'm trying to redirect their energy and focus if I can. And there it is. Use the person's knowledge of their person to join their reality. Again, I'm going there with them. If they say the sky is purple, that's great. That's my favorite color. I don't need to correct them, because the other mantra that we use is, so what? If they're not hurting themselves or anybody else, so what? It's okay. It's all right. And that's half the fun of being a caregiver for someone with dementia, is you get to be in all these different worlds all day long. So go there with them and have fun with it. So knowing the person, really helps you kind of develop a plan, where they were raised, so you wouldn't want to talk to somebody who was raised on a farm about growing up in a city, because they don't know, so go there with them. Where were they raised? What were their lifestyle like when they were younger? Because with dementia, long-term memories stay. So they're going to remember those long-term memories. So they can't tell you what they had for breakfast this morning, but they'll be able to tell you when they got married, how they met their husband, their favorite class in high school, their first job. So use all of that knowledge about them to care for them. Past and current family dynamics, and this works in a positive and a negative way. I've taken care of folks, I took care of a gal one time, and she was in a very abusive relationship when she was very young. And when she was older, in the midst of her dementia, she was sort of reliving that. So we knew that about her. So then we had to adjust how we cared for her when she was in a moment where she was really upset and the man was going to get her. And, we had to reassure her that she was safe and it was okay. But, to tell her that, that he's nowhere around, that's fine. That wouldn't have worked. We needed to go there with her and be like, it's okay, you're safe. Former occupations, obvious reasons why that's a good idea: likes, dislikes, hobbies, and routines. Folks with dementia need routine. They need that routine for sure. So addressing physical needs, all these things are physical: clothes too tight, shoes fitting, do they have a sore throat, are their dentures not fitting? So really look at the big picture. If there's any physical needs going on, address those first. We want to assess for pain. That's part of the physical assessment, which can be hard, especially if we're not trained in the medical field. But so some things to look for when we're assessing for pain, facial expressions, grimacing, gritting of teeth, clenched jaws, body movement. Are they guarding? Are they holding their stomach? Those can all be clues to pain. Negative vocalization, sometimes they'll be able to tell you, I don't feel good. My tooth hurts, my face hurts, my head hurts. Changes in interactions. So, if they're normally pretty outgoing and all of a sudden they're really become withdrawn, there's a clue that something is going on. Same with changes in sleep and eating patterns. If they're a really good eater and all of a sudden they're not eating, maybe they're constipated. Maybe, there's something else going on. Maybe they have a stomach ache. And sudden changes. Sudden changes it's not a typical part of dementia. Dementia is a very slow progression. So if you do have a sudden change, consult a physician, get a doctor's appointment, because that could be a sign of possibly a urinary tract infection or some other illness going on. That's usually what causes or triggers sudden changes. So when in doubt, consult your physician. Absolutely. Then the next thing we have to do is address emotional needs. So again, all those emotional parts that go behind what's going on in the behaviors. So role confusion, I think this is also hard for caregivers, the role confusion, because mom is always taking care of me my whole life, and now I'm taking care of her. And, That can be hard for parents too, especially in the earlier stages of the disease. Like, why are you treating me like this? Why are you telling me I need to take a shower? I'm your mother, I'm an adult. Loss of meaningful activity, again, just really looking at that purpose for them. So all these are emotional issues: lonely, scared, anxious. Think of the big five: that fear, frustration, fatigue, physical discomfort, and environment. Those will all play into emotional issues as well. All right, so once you've addressed the physical and the emotional, then you can kind of reassess, well, what did we do? What worked? What interventions did we try? Did we try redirection? Did we try validation? Were they successful? Well, yeah, this one worked, but this one really didn't. So we'll try this one next time first. And then again, communicating what worked and what didn't with other care partners and other people in the family. So what is redirection or successful redirection? The very first thing you have to do is be friendly. Again, a smile goes a long way. If you come in with kind of arms crossed and a scowly look, they're automatically going to shut down. So you really have to be friendly. Do your best to approach from the front, and sometimes just small talk and little compliments. A big thing that we hear a lot is, I want to go home. I want to go home. I want to go home. Well, what is home? Again, focus on the feelings, not the facts. Is home their childhood home? Is home the home that they raised families in? Is home the bathroom? I mean, it really could mean a lot of things. So by doing small talk and kind of complimenting, oh, really? Well, where is your home? Did you have a big house? Did you live in an apartment? Kind of redirecting that feeling kind of gets them talking about something else, and we'll redirect them. And again, using your knowledge of that person, knowing their likes and dislikes. Let's go get some ice cream. That's a great one to use. And knowing their preferences. And then you can attempt to redirect. The power of an apology. Again, a lot of times they just want to be heard, and they want someone to validate their feelings and reassure them. So a sincere apology, even if you didn't do anything wrong, sometimes that's just what they need to hear. I am sorry. I am sorry that's happening to you. I'm sorry this is going on. Even if it's not anything you did, your fault, take ownership. Gosh, I'm really sorry that, your clothes didn't get put away correctly today. That was my fault. I will do what I can to make it right. Or I'm really sorry that your daughter has stolen your money. I will call the police, and we will do what we can to make it right. So again, just kind of validating. That's what an apology does, is just validates their concerns and how they're feeling, and joining their reality. So even if you didn't do anything wrong, it's okay to say you're sorry, because you are, in a way. You're sorry that they're feeling this way. There is a thing called therapeuticfibbing too. We sort of use this as a last resort, but it is, I use the example of someone asking for their parents, and their parents have been deceased for 40 years. To tell someone that their parents are deceased, that would be hearing it for the very first time, and they don't know that that's happened. So, you can imagine the emotional meltdown after they're hearing this. Why didn't I know? Why didn't anybody tell me? Oh my God, I never saw her. I didn't say goodbye, that kind of thing, even though it's happened 40 years ago. So again, we would try that redirection. We would try distraction. We would try talk, oh, well, what is your mom like? Is she a good cook? What was your favorite meal that she cooked for you? Really just getting them talking about other things. If none of that works, well, your mom called and she's stuck in traffic, so you're going to have dinner with us tonight. And she'll be here in the morning. Oh, okay. But it's better than trying to tell them, that mom has passed away 40 years ago. So really tell those emotional truths. Where is my mom? Well, your mom is stuck in traffic, or I haven't seen your mom around for a while. It's a fib, but it's true. Yeah, mom hasn't been around. She's out of town. So tell those emotional truths. And then the rule about therapeutic fibbing too is, if you get caught, you do have to fess up to it. So just real quickly, some challenging behaviors that you may see. Again, that confusion, main problem with dementia, most definitely. They repeat things, repetitious actions, questions, statements. This is more frustrating for care partners than it is for the person with dementia. Part of the reason they do this repetition is they're just trying to connect with you. They're trying to keep that one foot in reality. When my grandmother was diagnosed with dementia, my grandpa, he ended up in the hospital, and we knew somebody had to be with Nanny, and I was late teens, early 20s, and it was my night to spend with her, and she read me the same paragraph of the same newspaper article 17 times in a row. And I didn't know anything about this disease, so I was like, what is going on here? But that was her way of connecting with me. She didn't know what else to talk to me about, I think, and she was trying to keep herself kind of grounded in reality. So that's why they do that. And they honestly just don't remember that they've asked you that same question 25 times. Agitation and aggression can be, is a real behavior. Again, dealing with agitation and aggression, the key there is to be safe, keep yourself safe. So if it really is escalating to a point where you need to remove yourself from the situation, please do so. We're going to kind of talk about the ones that are underlined a little bit more in depth, but hallucinations and delusions, sexually inappropriate. We've kind of talked about suspicions. Sleep changes, very easy for them to get their days and nights mixed up. Sleep changes directly correlate with the next one, that sundowning issue. When they're tired, that's when sundowning happens. And then wandering. So hallucinations and delusions, pretty common, especially in other dementias like Lewy body dementia. That is one of the key components of Lewy, one of the symptoms that we see a lot with Lewy body dementia is hallucinations and delusions. Seeing, hearing, smelling, tasting, or feeling things that are just not there. And then delusions are firmly held beliefs and things that are not real. That my daughter stole my money. That's a delusion because it's just not real, but they're very set on that is. They can be caused by medical issues or environmental things. Again, it just depends on how the disease is affecting the brain. Some people have hallucinations and delusions. Some people never experience them. But what we really need to do is really go there with them and join that reality with them, and don't try to tell them it's not really happening. When they make the comment, "You stole all my money," we can't take offense to it. That's one of the reactions that we have on our part as caregivers, care partners, is not taking offense to any of this. It's not your mom talking to you. It's not your wife talking to you. It's the disease. It's the disease that's causing this. So we listen empathetically. We put ourselves in their shoes, right? We're not going to try to argue with them or try to convince them otherwise, because that's going to get us nowhere, and that's only going to make them more frustrated. So really, we just need to validate those emotions. Again, focus on the feelings, not the facts. Reassure them and redirect them if possible. Okay. Sexually inappropriate, this is pretty common too. They lose that social filter. Folks with dementia just lose that social filter. They're going to say it, they're going to do it. If they think it, it's going to happen. So a lot of times, especially in a care community, I have to remind staff, that they're not sexually harassing you. They don't have that, they don't know that it's not the right thing anymore. They've lost that social filter. So they could touch, they could grab, making comments. So we have to, respond without taking offense, provide privacy. A lot of times too, folks, especially in care communities and things like that, spouses have passed away, children don't come every day. So they need that intimacy. And intimacy doesn't always mean sexual. It's touch. It's a very basic human need, holding hands, rubbing backs, getting a hand massage with nice smelling lotion. Those are ways to provide non-sexual touch and contact. And people need that, in the very last stages when people are passing in a hospice, they need that human contact. And I think that's where this comes from. So again, validate those emotions, reassure them, and then try to redirect them to something else. We've kind of talked about sundowning. Again, it's just marked confusion, agitation, deterioration of skills. A lot of people are just better. You'll hear this a lot. They're just better in the morning. That's because they're fresh. They've had a good night's sleep. They're up. They've eaten well. So they're able to do more things. So, plan your day accordingly. If they're better in the morning, make doctor's appointments for the morning. Make the outings for the morning. Don't wait till late afternoon to make that doctor's appointment, because you're probably going to run into some troubles. Again, considering that mental or physical exhaustion, physical, yes, but I think mental more than anything. They've really been trying all day to keep up with the world around them, and their brain is tired. Increased noise and busyness of the evening, again, making sure that it's calm, it's quiet. We don't need to have the news on with all the horrible stuff going on, because they will definitely precipitate on that and think it's really happening to them. So be mindful of that. Reduced lighting and then increased shadows and reflections. So make sure we're turning the lights on. We're closing the blinds if you can see reflections in the windows, because they may see that as people peeking in the windows outside, that kind of thing. That's scary. So consider those environmental changes. Again, reviewing that daily routine. Focus on the person, not the tasks. We always say the joy is in the doing. It doesn't necessarily mean that we have to have a finished product. Or if we get them to wash their hands and wash their private areas, great. They might have not taken a whole shower, but that's okay, that kind of thing. So just be really person-centered. And again, that therapeutic fibbing, just making sure that it's the last resort, but if you need to use it, if it protects their feelings, it's okay. It's okay. And decrease demands. Don't just go with the flow. Don't try to expect a lot from them in the later afternoons. And then wandering. Of course, 60 to 70% of people with a diagnosis of dementia will wander. It's sort of not when, or it's not if, but when. It's considered an emergency, especially with someone with dementia. And wandering can happen not necessarily on foot. They can call the cab, they can catch a bus, they can, all kinds of things. Hitch a ride, hitchhike. 50% of individuals not found within 24 hours risk serious injury or death. So, you see it on the news all the time. Person with dementia is missing. We have to take those very seriously, because they do not have the ability to retrace their steps. They don't have the ability to even know where they are to tell somebody, I'm lost. So that's very scary. Paths taken are not logical. It's not necessarily like, well, they always used to walk this route when they go for their walks. That's a good place to start, but not always, what happens. Most individuals are usually found within 1.5 miles from home. We say search smart, not loud. We could be hollering around the neighborhoods, but they may not respond to their name. They may not want to respond to their name. So instead we have to think of, okay, well, where would they be going? What would they be looking for? What were they doing right before they left? Were they upset about something? There's also something called the dominant hand theory. If you're right-handed, a lot of times they say that people will walk out a door and go right. If you're left-handed, they'll walk out the door and go left. Something to consider. There are a lot of great technology interventions out nowadays. There's something called Smart Sole. It's an insert that you can put into someone's shoe. Granted, they have to be wearing their shoes, but then you can set a perimeter and it alerts your smartphone, the care partner's smartphone, if that person has gone beyond that perimeter. There's light bulbs, they're called stack lighting now, that you can get that, if someone is still living at home by themselves, the technology is amazing. It does circadian rhythms, and then it also detects motion. So when somebody gets up at night, it'll kind of read their patterns. So if they're up at night and it's 2 o'clock in the morning, and they usually get up to go to the bathroom then, but say they don't come back from the bathroom, it'll alert a smartphone that you might want to go check on so-and-so because they haven't come back yet. There's no motion in their room. So maybe false, things like that. All kinds of great technology out there. I know in Jefferson County we have Colorado Life Track. So there's GPS trackers that people can wear. And then if they do wander or go missing, they can activate that GPS. So all kinds of good stuff out there as far as wandering goes. So my last slide is we make the weather. Again, we are the deciding factor in this environment that really makes or breaks our day. So this is just an excerpt from a essay written by an actual caregiver at one point. And she says, I have come to the frightening conclusion that I'm the decisive element in the secured environment. It's my personal approach that creates the climate. It's my daily mood that makes the weather. As a caregiver, I have the tremendous power to make a resident's life miserable or joyous. I can humiliate or humor, hurt or heal. And in all situations, it's my response, whether a crisis be escalated or de-escalated, and a resident be humanized or dehumanized. And I think that's so true. You know, we make the weather, and we are that factor in that environment that can either make their days wonderful or add to their frustrations. Well, thank you very much. And I'll turn it over to you.
All right. Well, thanks so much, Stacy. While we get the PowerPoint up and running, I'll just introduce myself a little bit. I am Amy Miller. I work with the Senior Reach program at Jefferson Center. I'm also the national consultant for that program. We're a program that really works to get isolated, vulnerable older adults connected to behavioral health services. So I'm very happy to be part of this program, this webinar, and we'll dive right in. So what I'm hoping to cover today is really just to give you some information about the common emotional and mental health concerns that happen in later life. Things like depression and anxiety can manifest very differently with an older adult compared to a younger adult. And so it's important, I think, to know the warning signs that can sometimes be easily overlooked. And then we also want to talk about different communication strategies and other techniques that caregivers and family members can use to help, address some of those concerns, as well as give you some of the resources that exist in the community to help address those needs if they're needing more of a professional level of intervention. So I did want to start by talking about how common some of the behavioral health challenges are in later life. According to the Centers for Disease Control, about 20% of older adults experience some sort of mental health concern. And so you can see some are more common than others. For depression, there's estimates of anywhere from 15% in the general population for older adults. Once you start looking at people who are showing up to aging services providers, it's closer to 31%. And so that's the most common issue that older adults are facing, most common mental health issue. Anxiety is right behind it, similar ranges from 14 to 27%. We also have a quarter of older adults who are on some sort of psychoactive medication, so something that's impacting their sleep, their mood, their thinking. And a pain medication, it might be a medication to help them sleep, but there is that potential for misuse. And then additionally, a significant portion of our older adults are also at risk for problem drinking. And I think substance use is not always a concern that's at the top of mind when we think of older adults, but it is incredibly common because, as you can see on the next line, about 1 in 5 people have that potential for misusing their medications with alcohol. And then I think another important thing that we'll dive into more depth on later is the fact that a lot of our older adults have experienced a traumatic event. The longer we live, the more likely we're going to experience something traumatic at one point or another. And have they ever had the chance to really address that? I think that's something to keep in mind. So those are kind of the top concerns. I do want to stress, though, behavioral health issues are common, but they're not a normal part of aging. Most older adults age very well. They cope very well with the challenges that come in later life. They have their supports. They're able to manage, and most people age well, age happily. So I don't want to inadvertently add to any stigma around aging because it's a very positive time for most people. But of course, we need to know how to support the people who are struggling and know how to support them as well. So one of the most common changes that can happen with a person is changes in physical health. Of course, with later life, we have more medical conditions that creep in. So a huge concern for older adults are changes in mobility. That can make it really hard to get around, to get out to social events, and that can really contribute to someone's sense of isolation. And about 40% of older adults have some sort of challenge with their mobility. Right behind that is chronic pain. We'll talk a little bit more about that later, but that can also significantly impact someone's ability to cope. Similarly, hearing problems, vision problems, managing chronic conditions like diabetes and high blood pressure, COPD. And I think too, medications, Stacy touched on this, and medications are a very common part of our older adults' lives. For people 65 to 69, they're filling about 14 prescriptions a year. By the time you're 80 and up, it's 18 prescriptions a year. Some of those might be temporary, like an antibiotic after a dental procedure or something like that. But it's very common that people are on multiple medications, and those interactions can contribute to their mental health concerns. And then similarly too, with COPD, if someone is having trouble breathing, that could definitely contribute to their anxiety. If they're having trouble with hearing and vision, it's harder to interact and they become socially isolated, and that can increase their sense of depression or anxiety. And then of course, most people don't have just one of these. They can kind of occur together very commonly. So it's just important to keep in mind of how those physical changes really might be impacting the rest of their world, the rest of their experience, and how we can help support the changes and give them the accommodations they need to keep engaged and keep doing their activities that are important to them. So like we said, with chronic pain, about 39% of older adults experience it at any time. Lots of different potential causes, everything from pressure ulcers, stomach or digestive issues, of course, things like arthritis, peripheral neuropathy, diabetic neuropathy, side effects from cancer treatment. One thing I think to point out too is depression can cause pain for anyone, but particularly with older adults. It's quite common for that to be the presentation of depression. So there are lots of things that can contribute to that chronic pain. And of course, I think the important part is the impact. If you're in pain, you can't get out and about to do your usual activities. You're more at risk for falls. Pain contributes to depression, anxiety, and if you're having trouble sleeping, that just decreases your ability to cope as well. And then of course, if you're in pain, you might be more irritable, having more struggles with your relationships with your family and your friends, and that can really increase your sense of isolation. So this is a very significant issue that I think often gets overlooked with older adults. And depression, like we said, anywhere from 15 to 30% of older adults have depression. And the ones that are bolded, if you can see, are really more common symptoms for older adults. So for younger adults, you see more of the affective symptoms, the crying, the looking depressed, the feeling depressed. Whereas with older adults, you see more of those aches and pains that don't really seem to have any physical cause behind them. It's also more common to see memory problems and confusion. And oftentimes people are suspecting dementia because of the person's age, but really with depression, they don't have the energy to put into their cognitive functions. And so it can look like dementia. And then once you address the depression, all of a sudden their cognition becomes much sharper again. So it's always good to look for depression if you're concerned about someone's cognition. You may see someone with a loss of interest in living, fixating on thoughts of dying or thoughts of suicide. White men over the age of 85 have the highest suicide rate in the country. It's a very common concern in later life and one that needs to be taken very seriously. And you can see with the loss of self-worth, the worry about being a burden on your family, and sometimes that lack of meaning and purpose that can happen in later life. If they've retired, their kids are grown, you know, if that was their role and they haven't found a way to fill that void, it can be very easy to have that feeling of worthlessness or hopelessness. So that's where bringing in that support can really help them, you know, find those strengths that they have, find the new roles that are meaningful for them. Another point I want to point out is also with dementia, 40% of people with dementia also have depression. Those deficits can trigger depression as well. So it's always important, I think, to screen for that, because again, they're probably not going to be able to self-report, boy, I'm feeling down, I'm feeling worthless. But if they're very irritable, or you know, they're constantly having delusions of terrible things happening, it's really worth looking at whether or not they might be depressed as well. So these are some common risk factors for depression. I won't go through them all, but as you look at them, you can see many of them are very common experiences for people in later life, experiencing death or loss of friends or family or pets. That's actually, we get a lot of referrals into our program because someone has lost their pet and they feel silly because they're taking it so hard. But when you think of an isolated older adult and their pet is their companion, their lifeline, who they talk to, it makes total sense that that could just be devastating for them. Moving, maybe they can't manage their house anymore, and so they've had to move into a retirement community, and all the stresses that can come with community living are adding to their stress experience as well. All the things we've talked about that contribute to social isolation, that loss of independence or fearing the loss of independence. We know a lot of older adults are on very limited financial resources. They may have experienced some abuse or trauma and haven't really had a chance to resolve it. So you can see where things can start to snowball for an older adult very quickly. And I think that's why it's so important to identify when someone is struggling early before more of these things start to pile on top of each other and you're ending up with a much more kind of stressful situation. So similar to anxiety, it can often be overlooked in older adults, because if you look at those physical symptoms of chest pain, shortness of breath, GI issues, well, we just talked about how common, medical conditions are for older adults. So a lot of times it takes quite a while for someone to rule out all those physical causes that could be contributing to those symptoms. And with behavioral, if they're avoiding certain situations, avoiding people, isolating themselves, they don't want to leave their house, it's difficult for them to get out to the doctor to talk about this or fully explain to the doctor what's going on. They're more likely to report those physical symptoms and not, the psychological or behavioral symptoms of, well, and I'm also worried all the time that something terrible is going to happen, and I'm irritable and I'm snapping at my family and I don't want to leave the house. They're not as likely to talk to their primary care physician about that. They're going to talk about, they feel dizzy, they have stomach issues. So again, if you don't know what to look for and what to ask about, it can be very easy to overlook. So very similar risk factors for anxiety. And again, just very common occurrences that can happen in later life. So again, just this underscores the importance of intervening early. The good news is it also gives us a lot of places where we can intervene. And, if someone is having trouble adjusting to their move to a senior living community and they're feeling depressed and, they miss the friend that they had who, they used to go to the movies with every Tuesday. I mean, there's 3 different things that a counselor or a family member could work with that person on. Maybe finding them someone else who could go to the movies and keep that tradition alive if that's important to them. Maybe someone who can help introduce them to other people in the senior living community or problem solve the conflict they have with the next door neighbor, things like that. Grief and loss, of course, very common experience in later life. Loss of spouses, loss of adult children. We see that quite a bit as well. And then also just loss of maybe the home they lived in. Like I said, if they had to move in with family or to a care community, that can be a huge loss. Loss of their routines, loss of their physical health. I think it's more than just the death of someone important to them, just the loss of other things that have been important to them in the past. So reactions, of course, are going to vary from person to person, and it's really going to be influenced by their culture, what's an appropriate expression of grief, who's it appropriate to talk to. And again, most people move through their grief on their own, just unassisted, without needing any sort of extra professional support. But there are about 10% of people who experience that prolonged or complicated grief who really do need an intervention to help them move through it. And we'll talk toward the end about ways you can support someone. So these are some reactions you might see in someone who's experienced grief. Preoccupation with thoughts of the deceased person, of course, crying. The things like disbelief. They just can't believe this happened, can't accept that this happened. They're just stunned. Or if you see where they maybe don't seem to be grieving at all, those are things that you want to keep an eye on. That at some point down the road, that delayed grief is probably going to show up in a very intense way. And so it's really important to keep an eye on whether or not someone may be having a hard time going through it. Grief is normal, but it is painful, and you have to go through it to get past it. And so it can be hard. That's a painful experience, and a lot of times a person will just do everything they can to avoid experiencing it. But you do have to let yourself feel that pain to move through it. So we'll talk a little bit about some ways you can support someone in doing that. And I think just that education piece is a huge one, letting them know, we have to find some way where you can let these feelings out. So I have up here a list of different signs and symptoms. So things like anxiety, depression, incontinence, memory loss, poor hygiene, legal problems, financial problems. And if you saw an older adult who was experiencing these symptoms, what would you think might be going on? If there's someone in the room, you can shout out a guess. Stacy says dementia. Yeah, definitely. I don't know if anyone in the chat box has some ideas, or a urinary tract infection. Absolutely. And those totally could be going on. These are actually all signs and symptoms of substance use disorders as well. And so again, it can be really hard to identify, easy to overlook. And so I think it's important to again, let people know this is definitely an issue in the older adult community, and it can really be easy to misidentify as well. So those who are most at risk are women. Women have a higher risk of developing substance use disorders in later life, partially because they have more access to psychoactive medications, pain medications, sleep medications. I think doctors sometimes assume that women are less likely to abuse them, and so they prescribe them more to women. Or women are more likely to go to their doctor and ask and, share with their doctor that they're struggling with something. Those, of course, who are socially isolated, all of these concerns, it all comes back to social isolation. If you're socially isolated, you're at huge risk for other issues. There was just a study that came out of Brigham Young University, AARP referenced it. Being socially isolated is as deadly as smoking 15 cigarettes a day for an older adult. And so if you can do nothing else, get that person reconnected to their family, community, surround them with eyeballs. That will do so much and will go so far. So of course, those who've had a history of substance abuse and maybe they've been in recovery for a while, but these stresses of later life have made it hard to maintain their sobriety, that can definitely increase a person's risk of relapsing or going back into active using. And then of course, if they have any sort of mental health disorder on board, especially depression, it's likely that they may use substances to help cope. So, of course, these can have some significant consequences in later life, everything from falls, hip fractures, traffic crashes, negative health effects if they have a liver or kidney condition and they're not supposed to be drinking and they are. Of course, that's going to exacerbate the problems caused by their health condition. We've talked about how they may be on 14 or 18 medications, and alcohol can interact with many of the medications that are commonly taken by older adults. So that's always something to be on the lookout for. And of course, as we age, our metabolism slows down and we don't process substances as quickly as we used to. So it could be that, they've always had 2 glasses of wine in the evening with dinner and that was always fine, but as they've aged, they've slowly become less tolerant to alcohol, and all of a sudden it's having much more of an impact on them than it used to. Diminished intellectual functioning, if there's something like an early stage dementia on board, of course, alcohol does not help any of our cognitive functions, and so that can only exacerbate what's already going on. And then again, straining those relationships, and that increases that risk of social isolation. I do also want to talk about unresolved trauma. So we can see where up to 90% of people, 65 and better, have been exposed to at least one traumatic event in their life. And up to 15% have subclinical levels of PTSD symptoms. So maybe not enough to make a diagnosis, but the symptoms are definitely present. 70% of older men and 41% of women have experienced trauma or traumatic event or have those subclinical symptoms. Any idea why men might be at higher risk for PTSD symptoms? Military service, yeah, absolutely. Those men who served in the military saw traumatic things or experienced traumatic things. That is why they have an increased risk. And for women, it tends to be more domestic violence type of situations that they've experienced. So I think it's important too to recognize that older adults might not always identify as having experienced trauma. I had a client once who had experienced domestic violence in her marriage, and we talked about PTSD. And I asked whether or not she thought she might have it, and she said, well, I can't have PTSD. I wasn't a vet. And they've made that connection of, PTSD is something that only military service members have gone through. And so this is important, I think, in terms of again, providing that education around, well, actually PTSD can happen to anybody. And trauma is a subjective experience. So I think this is just a fascinating study, the ACE study, the Adverse Childhood Events. And what they found is at least 2/3 of adults have experienced one of these traumatic events in their childhood. So either physical, emotional, or sexual abuse, physical or emotional neglect, or some sort of household dysfunction. So a family member with a mental illness, a mother or parent who was treated violently, divorce, a relative who was incarcerated, or substance abuse in the household. So as I said, 64% of people have at least one, but it's unlikely that they've only experienced one. These usually go together. And so if you have one, there's an 87% chance that you have two or more. And the more of these you have, the higher your risk for things like chronic disease, mental illness, becoming a victim of violence yourself in later life. And so what they found are these outcomes that are connected to having experienced traumatic events in your childhood. So people who've experienced trauma are less likely to be physically active, more likely to smoke and have heavy use of alcohol or drugs, more likely to miss work. And then of course the medical conditions, obesity, diabetes, depression, suicide attempts, STDs, which may not seem to logically connect, but when you think about they may be more likely to engage in risky sexual behaviors, that starts to, I think, come together a little bit more. Increased risk of heart disease, cancer, stroke, COPD, and broken bones, which again, may not kind of logically connect, but again, if you think of someone who's experienced trauma, who maybe has a hard time truly distinguishing between what's a safe situation and what's an unsafe situation, again, they may be engaging in more risky behaviors, which can lead to those broken bones. So people who have an ACE score of 4, who've experienced 4 of those adverse childhood experiences, are twice as likely to become smokers and 7 times more likely to have an alcohol use disorder. It also increases the risk of suicide by 1,200%. So it's a huge issue. And when you think of an older adult and the services that were available when they were children or young adults to address trauma, I mean, we know there's limitations now in our child welfare systems or our mental health services, but they were non-existent for a lot of older adults when they were growing up. And so they, again, maybe never got any support around this or never had a chance to address it. And now they're experiencing these more challenging outcomes. They're more likely to engage in violence, have more marriages, more drug prescriptions. People with an ACE score of 6 or higher, so people who experience 6 of these negative experiences, have the risk of their lifespan being shortened by 20 years. They live 20 years less than the rest of us, and so than the rest of the population. And so I think it's just really important to be mindful of the fact that an older adult has probably experienced trauma, has maybe not gotten the support in the past to address it, and now has all these other stressful life events happening on top of it that may be bringing up some of this trauma again. And so it's really important to be mindful of that. So again, the impact over a lifetime, these things happen in childhood. It disrupts our neurodevelopment, disrupts our social, emotional, cognitive development. So we're more likely to engage in those high-risk behaviors, which increases our risk of disease and disability, which shortens that lifespan. So again, it all connects together, and it just underscores the importance of really offering that support. Because we know with older adults, their coping skills that they may be always engaged in. So they always just kept themselves really busy with work, or they ran marathons, or they used substances perhaps, and now they've got a medical condition where they can't exercise, use those substances. They don't have work or family around to distract themselves. And they've never really learned other coping skills yet. It can really, again, start to snowball. And yeah, it's important for us to step in, get involved, get them connected to services to help them learn how to cope with these situations. So there's some very simple interventions that anyone can do, family members, caregivers, anyone coming into contact with an older adult. I think the main thing, allowing them control. So if you're helping them, if you're a caregiver for them, supporting them in some way, asking them how they like to have things done. You know, do you like to have breakfast before or after you shower? Things like that. Offering them options and letting them kind of set the agenda whenever possible goes a long way towards addressing those feelings of helplessness or anxiety or a lack of purpose. Listening to them non-judgmentally, you know, not saying, oh, well, you shouldn't feel like that. You still have your spouse. You still have your kids around. You know, why are you sad? Other people have it so much worse. You know, that's not supportive. We really want to validate those feelings, validate their struggles, their experiences. Avoid giving advice unless they ask for it. Sometimes we want to jump in and fix the problem, and really, like Stacy said, it's a universal need that we all have to be heard and understood and validated, and not have someone just kind of jump in and try to fix everything. And I think another thing is always to just give them feedback and reinforce the positive things about them. You tell the best stories. You make the best chocolate chip cookies. I just love coming here. You're so great with your grandkids. You know, whatever the case might be, again, just goes a long way in terms of, you know, fighting that depression, that loss of purpose, that loss of identity that they might be experiencing. Again, if nothing else, reducing their isolation, rallying the troops, getting family, friends, if they're a member of a spiritual community, whatever the case might be, just getting people connected to them again. It's very easy for older adults to become isolated. And again, that's the risk factor for so many things. So if nothing else, helping them get reconnected, re-engaged with their family, friends, community is just so, so important. Helping them with tasks. If they are physically unable to go grocery shopping and you can do that for them, or help them figure out an online or phone order, things like that, that can make a huge difference, because now they're able to eat again. That nutrition is helpful. They're not fighting hunger and weakness on top of their depression or anxiety. If they are physically able to, it can be good to help them prioritize their task. If they're feeling anxious and like there's just so much going on, helping them sit down and think through, okay, what's most important? What needs to be done today? And just helping them kind of triage things so that they're not feeling so overwhelmed. Letting the person reminisce. Life review is a really important task at this stage of life. So letting them look back and focus on their successes, what they've accomplished, the things they've done with their life, their strengths. So they have photo albums around, pull those out. Ask them to tell you stories. I love working with older adults because they have the best stories about, you know, the travels they took or the people they met or whatever the case might be. And so that's just a wonderful thing that anyone can do to help support them. And it's fun for you as well too. And then using those stories to point out their strengths. Wow, you really handled that so well when you had 4 little kids and your husband lost his job, and you really, you know, kept the household running. And, you know, again, show them their strengths, show them what they're capable of, and then, you know, help them identify those strengths that they might be able to tap into now to deal with some of their challenging situations. And I always think too, using humor. Don't be afraid to use appropriate humor. We don't want to, you know, laugh at someone else's expense, but pulling out, you know, the funny videos, the TV shows, what shows did they like? What did they find funny growing up? You know, especially if they've got cable news on all day. And again, they're just being flooded with negative information. But they, you know, if they want to watch TV, try to find something positive or funny that they can look at. Helping them, encouraging them to exercise. And again, this doesn't have to be sweating in the gym for an hour. Taking a walk around the block, taking a walk around the mall. But exercise is so good for endorphins, for our mood, for everything, for chronic pain. So this is a really great, I think, key intervention too, is, you know, start small, start with what they're comfortable with. You don't want to, you know, cause more anxiety because they feel like they can't do the exercise you're suggesting. But anything you can do and then build from is fantastic. Getting them sunlight. Again, if they're inside all day, getting them out into the sunlight. If you're in Colorado, we've got our 300 days of sunshine a year, or at least in Denver, and, take advantage of that. That does wonders. Sunlight, fresh air for mood. And with those two, food and hydration, I think, are really key. It's really common for older adults to become dehydrated, and that can lead to things like urinary tract infections, which can cause, like Stacy was saying, a delirium, or, very kind of dramatic changes in their mood and behavior. And even if it's not that dramatic, just we're not at our best when we're dehydrated. We're not thinking at our best. Our mood isn't at our best. So making sure those basic nutrition and hydration needs are met is really important too. If they're really reluctant to do anything, I always suggest people kind of pair activities. So you might say, well, let's walk around the mall, and that's your exercise piece. And then we'll go get our nails done. And then we'll go get some frozen yogurt. And then we'll go see a movie, whatever their interest is. If you can kind of pair it together, that might help increase their motivation to do that. Encouraging them to talk to their doctor if they're experiencing things like, sleep trouble, chronic pain, depressed mood, anxiety. Again, a simple medication review can do wonders, and that's something their pharmacists can do. They really don't even need an appointment necessarily. Encouraging them to get connected to some counseling, some mental health supports, and we'll talk about how you can find those supports a little bit later on. And then encouraging them to get reconnected to any sort of spiritual support if that's been an important part of their life, and that would be appropriate for them. So if someone's in the throes of grief and is having a hard time moving through it, there are a lot of different ways you can help them to mourn. And mourning is really grief made public. We do often have that. It's a real need. It's a real requirement for moving through the grief process that we make our grief public, that we share, how much we're hurting. And it doesn't have to be from the rooftops. It could just be with someone they're close to that they trust, but that is an important piece. So let them talk about their loss. It can be hard for us if we're not used to it. We can feel like we may become overwhelmed with their grief, but we don't have to say a lot. Letting them talk is really going to be the most helpful thing. Physical activity can help too, especially if there's a lot of just angst or anger around the feelings of loss. Helping them kind of channel that energy physically can be very helpful. Letting them journal, either maybe they're dictating to you and you're typing or writing, or if they're able to write it out, that can be incredibly helpful. Helping them create a memory book of the person, the pet, the home that they left behind, pulling out pictures and scrapbooking as a way to kind of honor that person and recognize the loss can be really helpful. Reading old letters, doing a favorite activity that they used to do with that person, with their pet. Making sure they're eating well, encouraging them to get enough rest, helping them find a support group, helping them with kind of creative or spiritual expression, things like painting or music can be really, really helpful. And when there aren't words, there's art. There's music. There are other ways we can communicate our feelings and our pain. And then again, if they're truly having a hard time moving through it, really helping them get engaged with a counselor who can do some more structured interventions as well. So some different things you might try that you may or may not feel comfortable with. You might feel totally excited and eager to research these and help the person you're supporting practice them and use them as well. If not, this is a great time to get them connected to a counselor. These are the types of things we often do with our clients on Senior Reach. So things like meditation or guided imagery are wonderful for anxiety, chronic pain, lots of different issues. And there's lots of great resources. You can find them online. YouTube has a lot of great guided imagery, meditation videos. You can get CDs if they're not connected to the internet. There's apps on your phone you can download. I use the Calm app, CALM. There's a lot of different ones. I think Headspace is another one, but they'll take you through guided meditation. They'll tell you bedtime stories to help you fall asleep, adult bedtime stories. They're fantastic. So lots of different resources out there. I think also just providing some education around the grief process and letting them know that what they're experiencing is normal. Because again, when we're grieving, it can feel like it's all consuming. We're never going to get out of it. And this is just the way it's going to be for the rest of our life. And so, explaining that it's very intense, but but it will get easier. We talk about, grief really coming in waves. And so you might just get hit by that wave of grief when you're in the grocery store and you see their favorite brand of cereal, or, when it's the anniversary of a significant date, things like that. Also, information around the stages of grief. Elizabeth Kubler-Ross and her stages of grief, which the stages are, denial, I can't believe this has happened, anger, why did this happen to me, bargaining, if she can just, beat this cancer, I will go to church every single day for the rest of my life. You hear things like that. Depression, and then acceptance that this is a reality and we need to move forward with this new reality. So I think the challenge with the stages of grief is a lot of times people see them and they assume, oh, it just goes right in that order. And once you're through a stage, you're done with it. You'll never deal with it again. And really you bounce around. You might go from bargaining to denial to depression and back and forth. And it can take a while to get to acceptance. And then even when you're in acceptance, again, you might get hit by that wave of grief and be right back into depression. And that's okay. That's normal. You just need to get that support to help you through it. So another intervention I like to use with clients is something called behavioral activation. It's great for depression. And it really kind of helps fight that downward spiral that can happen with depression, where I'm depressed, so I don't have the motivation or energy to do things or see people, and that just contributes to my isolation, which makes me more depressed. So you really kind of help them. The idea is to just find a few different activities, again, that target the different symptoms of depression. So you help them find an activity that's social. So maybe you help them schedule a coffee date with a friend. Something that they do just for the pleasure of it. Again, they go get their nails done, they go get a massage, they go play golf with a friend, things like that. I think the unique thing about this that we don't always think about, something that's gonna increase your sense of productivity. So it's been driving me nuts that I have this bill and I need to call and I need to have them correct this bill. They overcharged me and it's, it's just weighing on my mind, but I just can't deal with it. If you can help support them in getting that bill corrected, then that feeds that sense of purpose and worth, and I can do this, I can take care of things, I am capable, I do have a sense of purpose. It seems small, but it can be really impactful, and then we see people just building off of those small successes. And then again, helping them something that's going to solve a problem. I really need to get a grab bar installed in the shower because I'm afraid I'm going to fall. And so I'm not showering, and so I don't feel comfortable going out and seeing my friends. So if you can help them schedule a handyman to get that grab bar set up, again, feeds that sense of purpose and worth and ability to solve problems. So, so there's kind of those four key components: social, pleasure, productivity, and problem solving. And so if you can even hit one or two of those, it's great. But I think that's a real helpful thing that a caregiver can step in and do. There is one more intervention that I want to talk about for anxiety in particular. It's a grounding exercise, 5, 4, 3, 2, 1. So you help the person identify when they're feeling really anxious or agitated. You help them identify 5 things they can see. I see the clock on the wall, I see the water bottle on my table, so on and so forth. Then 4 things they can feel. Feel like I feel my feet on the floor. I feel my sweater on my shoulders. I feel my watch on my wrist, things like that. 3 things they can hear. I hear the humming of the air conditioner. I hear the dog barking outside. 2 things they can smell. And then 1 thing they can taste, or 1 thing that they like to taste. And it's good, if you have like a little thing of Lifesavers or peppermints, even to have them just pop that in so they can experience that sense of taste. And what that does is it takes us out of our anxiety and our headspace and gets us grounded back in reality. And then from there, we're better able to deal with the reality of the severity of the situation, and where things can feel so big and so, so overwhelming. Once we're more grounded, it's easier to see the true magnitude of the issue. I think keeping things like essential oils around to smell, things like that, that's all good too. These are also great things for caregivers who might be feeling stressed and overwhelmed to practice as well. So keep that in mind too. So I do want to, encourage those tips for caregivers in terms of practicing good self-care, making sure you're eating well, that you're hydrated, that you're getting enough sleep. It's not always possible, and I totally understand that, but making those a priority whenever you can. I think another important piece too is to set boundaries. If the person is irritable and verbally abusive, it's okay to say, it's not okay to talk to me like that. I'm here, I care about you, but you do need to be respectful of me, and to limit your time around the person. You know, especially if it's a situation where they're not willing to accept any sort of help at this point, you know, you have to do what you need to do to protect yourself and your mental health as well. So of course, taking breaks, getting support for yourself as a caregiver, educating yourself. NAMI, the National Alliance on Mental Illness, has great resources for family members, support groups, classes you can take. And then of course, make sure to maintain your own social support network, because isolation is just as much of a problem for the caregivers as it is for the older adult. So making sure you're staying connected to your friends and family and community. And then I think a big one is prioritizing those tasks. Sometimes as a caregiver, it feels like there's a million things on our plate that we need to get done. And this, I think, is a helpful grid. You know, it's urgent and important. And so you may have seen this before, but what's urgent and important? What's a crisis? So my loved one has a fever and they're disoriented and they're confused and I need to get them to the ER. That's urgent and important. That needs to happen right now. Urgent and not important are things like really distractions, email, someone's texting me, someone wants an answer right away. So those are things that you can maybe delegate or eliminate. Not urgent and important are more of those long-term goals, like meeting with a financial planner, researching respite options, researching care communities. It's things that are kind of easy to put off, but that are important to happen. So you want to make a plan for when you're going to tackle those tasks. And things that are not urgent, not important, things you don't want to do, reorganizing your linen closet, hopping on the internet for a few hours, you know, eliminating those wherever you can. So again, for different interventions, make sure they're connected with their primary care provider. Try to get them a referral for counseling. Often the primary care providers can help with that. Senior Reach is available in many of the Denver metro counties. Those are the phone numbers for that. Even if you're not in one of those counties, give us a call. We usually know the resources that are available. For those in Colorado, there is the statewide Colorado Crisis Services. You can call that number. You don't have to be in crisis to use that service. They can also make a referral for a local therapist, for a local mental health professional to you. And then for those from other states, this graphic from Mental Health First Aid has some great suggestions about how to find a counselor. A lot of times if on your insurance website, there's a Find a Doctor feature. You can use that to find therapists as well. And then just some different tips and questions to ask. And since this is going to be up online, I will leave it there. And I think from there, we've got some time for questions and answers if there's any from folks on the phone or any in the room. I'll invite Stacy back up to answer any if there's any that come up.
Nothing online yet.
So as a caregiver, what do you do if the person you're caring for resists getting help or denies that there's anything wrong?
Yeah, absolutely. So that's a very common experience. They find on average it takes someone 10 years to ask for help or find help for a mental health issue. So it may be that they're not ready, and there's a whole model around stages of change we could talk about. But basically the idea is if they're not quite ready to ask for help or engage in therapy, it's still good to have that conversation, to introduce the idea, to let them know lots of people experience this. It's common. We want to normalize it. We see this with Senior Reach. Anyone can make a referral to Senior Reach, and then we reach out to the older adult. And a lot of times they're not quite ready, and that's fine. We usually send them a brochure or offer to check back in a few weeks. And many times they've had, that time to think things over, to pay attention, to really actually, yeah, things have been pretty hard, and I am having trouble coping. And so then they're ready. And so it definitely takes time, and people have to move through those stages of change. Again, as the caregiver, that's really hard to cope with when you see someone struggling or they're taking out their frustrations on you. And that's where I think, setting those boundaries, setting limits around how often you're going to show up, what sort of communication you are and aren't going to allow from them, and getting support for yourself and educating yourself is really critical. Anything to add, Stacy? I mean, that happens with early stage dementia too. Yeah. Anything else on the webinar? from folks on the webinar?
Don't say anything yet.
Okay.
Thanks.
All right, well, thank you so much. And Megan, do you want to take it over and wrap it up?
All right. Thank you so much to Stacy and Amy. I hope you guys learned a few things. I certainly did. Just a reminder that we will be sending an evaluation as well as posting the recording links on JFK Partners website as well as the Colorado Respite Coalition.org website. So definitely check it out. For those in the room and those on the webinar, there's also a training and discussion guide available, which is a great tool if you want to take this back to your own organization or your own team and kind of go through some of these things with real life situations that you're dealing with. But thank you so much for your time and have a great rest of the day.